we see if everything is in order.
Is my slides visible?
Yes, thank you very much. That's great. Okay.
Yeah, okay. Great.
So you can remove so that maybe we can start off with the introductions.
We're not yet online, are we? Or we're already online?
We have 67 participants who have joined. So let's just give 1 more minute, then we can start. Okay, thank you very much. Welcome everyone to our WHO Southeast Asia Regional Antimicrobial Stewardship Webinar Series. And today we are on the module number 3, and we are going to focus mainly on introduction to antimicrobial stewardship and the principles of antimicrobial prescribing. So just for housekeeping, this webinar will be conducted in English, and as an attendee, your audio and video will be muted during the webinar. You can type in your questions in the Q&A section, and feel free to direct your question to any panelist if you so wish. You can use the chat box as a back channel for chats, discussions, comments that you may have. So please feel free to test it. You can type in the chat box your name, your affiliated organization, your profession. So the presentations of this webinar and previous webinars can be accessed on the Antimicrobial Stewardship Webinar Series webpage. So as you can see, we have an exciting agenda that is ahead of us, and this webinar will be for 90 minutes. So please feel free to send us your comments in the chat box, or you can send us an email directly. So at this point in time, before we start our presentation, I would ask Ms. Eugene Kim to give us some opening remarks. Over to you.
Good morning, good afternoon, and good evening, colleagues and participants. Welcome to the 3rd Antimicrobial Stewardship Webinar Series from the WHO Regional Office for the Southeast Asia. Today and at the next webinar series, we will be introducing antimicrobial stewardship elements and AMS during COVID-19 with experts from the Christian Medical College, Vellore, India. While tackling AMR requires multisectoral and One Health approach, prioritizing actions at the human-animal environmental interface, promoting appropriate use and reducing misuse and overuse of antimicrobials is the key in reducing antimicrobial resistance and improving patient outcome. Antimicrobial Stewardship Program is an organizational or system-wide healthcare strategy to promote appropriate use of antimicrobials through the implementation of evidence-based interventions which could advance patient safety and improve outcomes. There's no one-size-fits-all approach to optimizing the antimicrobial use for all settings. The medical decision-making surrounding antimicrobial use at various healthcare settings is very complex. However, some of the guiding elements to consider are due consideration to the national and local context and structure of the healthcare system, focusing on activities that will provide the greatest benefits based on national and facility needs assessments, strengthening and making use of existing platforms and coordinating mechanisms and resources to implement integrated AMS activities, supporting linkages and synergies between relevant disciplines, including surveillance, IPC, WASH, and various communicable disease programs. While WHO policy guidance on integrated antimicrobial stewardship activities and WHO practical toolkit for AMS in healthcare facilities in low and middle income countries provide useful recommendations, we hope today's webinar would showcase how AMS could be implemented with practical examples. We look forward to your active participation and fruitful discussion today. Thank you.
Thank you very much, Ms. Jean, for the opening remarks. At this point in time, let me introduce to you our speaker for the day. And this webinar has been organized by WHO Southeast Asia Regional Office in collaboration with Christian Medical College, Vellore. So our first speaker will be Dr. Priscilla Rupali, who is the professor in the Department of Infectious Disease in Christian Medical College, Vellore. She will then in turn introduce us to the panelists. So at this point in time, I hand over to Dr. Priscilla.
Thank you, Terence. It's my pleasure to introduce my very esteemed colleagues. The first person I'd like to introduce is Dr. Balaji. Dr. Balaji is a professor of microbiology at the Christian Medical College in Vellore. He has done extensive work on antimicrobial resistance, and he runs a very good quality assurance programs, which actually helps many laboratories all over the country to be able to give appropriate antibiotic susceptibility techniques. So Dr. Balaji, welcome to this webinar.
Thank you.
The second colleague that I would like to introduce is Dr. Divyashree. Dr. Divyashree has done her fellowship in infectious diseases at the Christian Medical College in Vellore, and she is right now works in the Mahatma Gandhi Institute at Navi Mumbai. She has extensive experience in infectious diseases, and she has actually single-handedly managed to implement antimicrobial stewardship at her hospital. So welcome, Dr. Divyashree, to this webinar. The third panelist that I would like to introduce is Dr. Vikas Desvar. Dr. Vikas Desvar is an infectious disease physician at the Medanta Medicity in Gurugram in Haryana. Dr. Vikas has an extensive interest in transplant-associated infections, in antimicrobial stewardship, and is also is part of the infectious disease unit at Medanta Medicity. So thank you very much, the three panelists, for joining us, and we look forward to interaction from you as we proceed with the moderation for this session. Terence, should we just go ahead with the presentation?
Yes, thank you very much. You can go ahead.
Okay, so good afternoon, good evening, good morning to everyone, depending on which part of the world you're from. So I will go ahead and try and share my screen and my slides. As Terence already mentioned, please feel free to use the chat to put in your questions. Our speakers will be, our panelists will be taking questions during the chat as well, especially if it is to do with regard to a case that has gone before. So this is going to be like a very basic kind of presentation where we're going to be dealing with comments that we see in clinical practice every day and how we can actually contribute towards stewardship and what are the easy things that we could implement in our hospitals, wherever you may be, whether in the primary care, the secondary care, or even the tertiary care. So I'll just go ahead and start and with an introduction to stewardship. And then we will do some practical examples where our eminent panelists will give their opinions as to how to actually handle these cases. So as you know, the emergence of antimicrobial resistance happens. You have a susceptible bacteria, they undergo a mutation, and these chromosomal mutations contribute to a resistant bacteria. The other thing that can happen is you can have resistant bacteria which are pre-existing, either from the same class or acquired from somewhere in the hospital or the community, where they may have plasmids, which is extracellular DNA, and this may get incorporated and give rise to new resistant bacteria. So any infection will have a colony of organisms which are contributing to that particular infection. In any colony, you will have one or two organisms which are actually resistant, and you will find that these resistant elements may be there in that particular. Under selection pressure of antimicrobials, you will find that the wild type actually disappears. And then these resistant organisms then go on to become predominant. So what exactly is antimicrobial stewardship? So as you can see here, bacteria not only transmit resistant elements to each other, but they also transmit it to human beings in the hospital and in the community. So why is it important? As you can see, this is a picture all over the world. This is the Global Burden of Disease Studies, which was mapping antimicrobial resistance. You can see here the Southeast Asia region actually has a huge problem with regard to antimicrobial resistance. So MRSA or methicillin-resistant Staph aureus, carbapenem-resistant Klebsiella pneumoniae, carbapenem-resistant Acinetobacter, extra in the spectrum beta-lactamase producing E. coli. All of these actually contribute to a variety of infections that we see commonly in clinical practice. There are a variety of stewardship guides that are available. This is a very nice WHO guide towards implementation of stewardship programs in the low middle income country settings. So what really is antimicrobial stewardship? So all it is really a coordinated set of interventions which is designed to improve as well as measure if your interventions are working. They measure the appropriate use of antibiotics by promoting the selection of the optimal antibiotic, the correct dosage, duration, and the route of administration. What we hope at the end of this is that it leads to improved patient outcomes and decreases adverse events, and that can be measured by AMR rates or Clostridium difficile infections, etc. Now, you know, AMR is rampant. There is a dry antibiotic pipeline in the Sierra region, the low middle income countries. We don't really have antibiotics which can target the gram-negative organisms that we encounter in clinical practice. So WHO has recognized AMR as one of the top 3 threats to human health, and most studies actually reveal that human use of antimicrobials is inappropriate in 1/3 of acute care settings. So very quickly, principles of antimicrobial stewardship. Step 1 is making a diagnosis using multiple data points. You want to treat patients, not blood tests. You want to send confirmatory tests to make sure that you're able to appropriately manage them 48 hours down the line. You want to limit empiric antibiotic therapy to life-threatening situations. You want to know the local antibiotic resistance patterns. You want to use the correct choice, the dose, route of antibiotics, depending on the PK/PD parameters of the antibiotics that are prescribed. You want to de-escalate once diagnosis is known and antibiotic susceptibility patterns are actually available. So we want to start smart. So use the correct antibiotic if you have to give antibiotics empirically. So choose the right kind of patients where you want to start the antibiotics, or maybe you want to just wait and see whether you can get a diagnosis 48 hours down the line and initiate appropriate antibiotics. Let's say you start smart, and then you want to focus 48 hours later. So clinical review and decision at 48 hours, at which point, hopefully microbiology is available, the clinical picture is clearer, and you could make a decision whether to stop, to switch from IV to oral, maybe change to a narrow spectrum agent, or continue and review after 48 hours. Or you can decide which patient can go on to an outpatient antibiotic therapy setting. So there are very specific clinical situations where antibiotics can be stopped. So these are the various respiratory tract syndromes, all viral syndromes, whether it's pharyngitis, rhinosinusitis, bronchitis, a variety of non-infectious cardiopulmonary disorders, whether it's heart failure or renal disease, can be misdiagnosed as pneumonia. So it's important to actually make a diagnosis so that we can practice stewardship appropriately. There are a variety of acute otitis media. Most of them are viral. There are very few which are actually bacterial. So it's important to recognize and be aware that antibiotics can be stopped. Skin and soft tissue infections, if they're uncomplicated, like small subcutaneous abscesses, just a dermatitis, does not need antibiotics. Asymptomatic bacteriuria, pyuria does not need it. Microbial colonization, culture contamination, low-grade fever, all of them do not actually need it. Now, there's a lot of work done with regard to duration of antibiotic therapy, whether it's community-acquired pneumonia, healthcare pneumonia, skin and soft tissue infections, urinary tract infections, Staphylococcus aureus bacteremia. Here you can see that it requires antibiotics for about 2 to 3 weeks, depending on how complicated it is, intra-abdominal infections, and surgical antimicrobial prophylaxis. So what are the golden rules? Microbiology should guide therapy wherever possible. Indications have to be evidence-based. The narrow spectrum should be chosen. The dosage should be appropriate to the site and the type of infections. And you need to minimize the duration of therapy in most cases and try and see whether monotherapy can be ensured in most cases. So an AMSP team or Antimicrobial Stewardship Program team should have a physician leader with infectious disease training, can be co-led with a pharmacist leader with ID training. It should be prescriber-led because it's easier to convince clinicians to be able to stop it. There should be a buy-in from all the heads of departments of all clinical teams. Infection preventionists or hospital epidemiologists can monitor, audit, analyze, and report facility-wide data. Quality management staff can audit and ensure that there is medical quality and ensure that it's a patient safety priority. Microbiology lab, extremely important. Antibiograms have to guide empiric therapy, and IT staff can integrate stewardship protocols into existing workflows. Nurses can ensure cultures are taken before starting antibiotics. So there has to be a leadership commitment, there has to be accountability, there has to be drug expertise, there should be a multidisciplinary approach and prioritize introduction of various policies which can lead to appropriate antibiotic use, measure, report, and then provide ongoing education. It is a patient safety priority, and that's a very important point to be understood across all tiers of healthcare. There has to be management support and accountability, a multi-professional AMSP team, effective communication structures, which is very important to be able to make it a success. Evidence-based stewardship interventions have to be the ones which should be implemented, education and innovation, and ensure that there are early short-term wins and then consolidate success. So this is with regard to the basics, and a lot of lectures have already been taken in these webinar series with regard to the implementation of an AMSP program. Now, I'm an infectious disease clinician, and we have very strong clinicians and microbiologists on our panels. So let's go on to the various other strategies. We know that these are the interventions which improve antibiotic use. They can be persuasive or restrictive. So they can be audit and feedback mechanisms, they can be reminders, or they can be formulary restrictions or stop orders or something that requires pre-authorization or expert approval. So we call these front-end strategies or back-end strategies. So front-end strategies are where it goes through an approval process, so it is restricted unless it is pre-authorized by some member of the AMSP team, whether it is an infectious disease physician or a pharmacist or a microbiologist. This leads to an immediate reduction in the use and expenditure. Back end is a little more collaborative, where you come back after antibiotics have been prescribed, so you don't really take away the prescriber autonomy, and then you dialogue with them with regard to timely de-escalation of antibiotics or reduction in inappropriate use. What are the interventions which are evidence-based? Formulary restrictions and pre-authorization, a prospective audit with intervention and feedback, multidisciplinary stewardship team, streamlining and timely de-escalation of therapy, dose optimization, parenteral to oral conversions, guidelines, clinical pathways. These are all evidence-based interventions which have been proven to be of use. So if you compare these two, pre-authorization of prospective audit and feedback, they have their own advantages and disadvantages. The advantages of pre-authorization is it immediately reduces cost, but there is a loss of prescriber autonomy. Whereas if you look at prospective audit and feedback, it increases the visibility of AMSP, and it is a more collaborative effort, which again maintains the prescriber autonomy, but is extremely labor intensive and needs a large team to be able to put it into practice. So we have an example of this. Now, for example, this is a healthy male who comes in with an acute abdomen, and the prescribing physician, the treating physician writes an order for injection meropenem 1 gram QA-bed. Pre-authorization works in that basically injection meropenem will not be given unless it's pre-authorized. Whereas prospective audit and feedback is the physician is allowed to prescribe, but then 48 hours later, a team comes in and says, okay, you've given it now, but can you go ahead and de-escalate or discontinue or modify according to antibiotic susceptibility? The other methodologies are didactic education. They cannot be relied as a sole means of reducing inappropriate antibiotic use. Facility-specific antibiotic guidelines based on antibiograms, which are given by the laboratories. These should be developed for common infectious disease syndromes, because that is what is going to reduce your antibiotic use. Prescriber-led reviews of antibiotic prescriptions can be done, and also a computerized clinical desertion support system, which can streamline and identify opportunities for interventions. These are also an example of an antibiogram. You can see here how it can inform antibiotic choice. It can track patterns of resistance, and it's a very key component of diagnostic stewardship, which I'm sure Dr. Balaji will be able to help us with. Okay, so very quickly, let's go on to the practical aspect of this, which is what everyone is waiting for. These are going to be questions directed to the panel after I present the case. So this is a 75-year-old male. He's a diabetic. Has a 7-day history of a swelling of the left lower limb with pain, bullae, and pus discharge. He also has a non-ST elevation MI during admission with a mild respiratory distress. He's shifted to the ICU. He requires intubation, but then undergoes a debridement and plantar fasciotomy. You can see here his vital signs when he came in, except for a slightly elevated blood pressure, were okay. But his laboratories had shown there was a mild leukocytosis, and you can see here his troponin T was actually elevated, probably as a result of his non-ST elevation MI. His chest X-ray had shown perihilar capacities. So this is his, these are his cultures. You can see her blood culture was no growth. His influenza PCR was negative because we were screening them. His superficial pus swab has shown that they were polymicrobial organisms, MRSA, Pseudomonas, Streptococcus. So a diagnosis of necrotizing skin and soft tissue infection was made, and he was started on injection piperacillin, tazobactam, and clindamycin. He was afebrile by the 3rd day, and CRP and procalcitonin came down remarkably. Subsequently, the patient was changed to linezolid and azithromycin. Okay, so I'm going to ask my questions to the panel here. So I'm going to direct my first question to Dr. Devishri. What is the most likely causative organism here? We had 3 organisms that were mentioned for this necrotizing skin and soft tissue infection, keeping in mind his comorbidities. So Dr. Devishri.
Yeah, so the swab actually showed 3 organisms, that is a Staph aureus, Pseudomonas, and Streptococcus. Keeping in mind with his comorbidities, one of the most likely, it is possible that in many patients the infection can be polymicrobial, especially the type 1 skin and soft tissue infections. It is possible staph is a very, very possible organism in this situation. One is because there is also a possibility of toxic shock syndrome, also the way he had a little bit of cardiac dysfunction and multi-organ dysfunction.
Okay, thank you, Dr. Devishri. So yes, your point is very well taken. It could be a strep pyogenes or a Staphylococcus aureus. My next question is directed to Dr. Balaji. Dr. Balaji, we know that many patients can have polymicrobial infections. Is there any clue which will tell us which is likely to be a true pathogen in a given setting?
Yeah, definitely, it's quite challenging because among the body sites, it's very challenging for us to distinguish colonizer from the pathogen, especially in 3 areas. One is skin and soft tissue infection, the most common and most challenging, followed by urinary tract infection and respiratory tract infection. So the worst, as I told you earlier, it's the skin and soft tissue infection. When we are taking a swab, what happens is majority of the time we collect the colonizer from the superficial area. So it's very important that you need to go deep and collect. So that's where you will get the true pathogen, that invasive. The true pathogen, in other words, it can be called as invasive bacteria, which damages the tissue and brings in inflammatory response, not the skin colonizer. So to get into the true pathogen, you need to collect the swab much deeper. This is almost equivalent to the invasive or bloodstream infection. So that is the most important one. If your sample collection technique is good, then you are clinching the diagnosis. If your sample collection is not good, then again, you are treating the colonizer along with the pathogen. Sometimes you may miss even the pathogen. And most of the time, skin and soft tissue infection, it may not be a monomicrobial. Often it's in a polymicrobial. And here the necrotizing, it's in one of the medical emergencies, especially more than staph or gram negatives. It's very risky for the life if it is due to Streptococcus species. It can be group A, group, any of the groups. So it's very important. It's in a medical emergency. First, you should cover always the necrotizing causing organisms, which is the most common is Streptococcus species and Staph aureus. So in this case, rightly, they've added Clindamycin, which not only takes care of both staph and strep, it is also excellent antitoxin antibiotic. So that way, it's really appropriate to give Clindamycin, added Clindamycin to this. Have I answered your question, Dr. Priscilla?
Yes, absolutely. Thank you very much, Dr. Balaji. My third question I'll address again to Dr. Devishri. Dr. Devishri, you saw this case and how it was managed. And so could you enlighten us as to what do you think are the various stewardship intervention opportunities with regard to antibiotic management in this patient? I'm going to go back one slide just to make it easier for both you as well as the audience.
So I think it's very appropriate that they have started the right antibiotics, that is piperacillin and clindamycin. I have a question that why was clindamycin actually started late in the course? Because it's very important that we start clindamycin very early in the course. Like I think piperacillin tazobactam was started earlier. It is 8 days and clindamycin is 5 days. So whenever there's a patient with necrotizing skin and soft tissue infection, you have to start clindamycin as early as possible. That is a very, very important aspect. Second thing is, it is very good that they have tried to achieve a source control, which is again important because that will help us in shorten the duration of antibiotics. And once you have a very good source control, and if the patient is improving and inflammatory markers are coming down, I don't think you need to have a very prolonged duration of antimicrobials after the improvement of the patient, because that will harm the good bacteria in the patient and impair his, further clinical improvement. So once you have a source control, I think 5 to maximum 7 days, or sometimes in patients with comorbidities, probably 10 days, that should be it. And there is no need to again change the patient to oral antibiotics and continue the antibiotics for another 2 weeks or something. Try to keep it as short as possible. Try to achieve source control as soon as possible. And once the patient is better, you have to try and stop the antibiotics.
Thank you, Dr. Divishri. So totally agree with you. So shorter the better. And clindamycin was started on the same day as piperacillin tazobactam, was stopped in 5 days' time. Whereas piperacillin tazobactam was continued, and then again they went on to give oral antibiotics. So totally agree with you. The clue here, the patient was afebrile by the 3rd day. CRP and procalcitonin had come down. So there was no really a reason to extend it beyond 7 days of therapy. So totally agree with Dr. Divishri here. Shorter is better, and numerous RCTs have demonstrated this. This is the step 4 trial. You can see here, intra-abdominal therapy here was given in patients where they compared 10 days versus 4 days after adequate source controls, and there was no difference between the two groups with regard to intra-abdominal infections and death. And numerous RCTs have demonstrated the shorter regimens are efficacious, whether it's bacterial sinusitis, cellulitis, community-acquired pneumonia. In fact, even in ventilator-associated pneumonia here, 15 versus 8 days, the shorter the duration of the antibiotics are better. There's a Cochrane meta-analysis as well, which shows that short course versus prolonged course really is of benefit. And most recently here, even in acute pyelonephritis and septic urinary tract infections, 7 days as well is actually of great benefit. Now, Dr. Vikas, I'm going to address one of the questions in the chat box to you. As a matter of principle, the use of antibiotics should be monotherapy, but how do we deal with it with regard to resistant bacteria, with regard to resistant TB, malaria, etc.? What is your comment on this?
So, with regard to therapy or it depends on the nature of the infecting pathogen and the site of the infection. Many times when we are dealing with resistant bacteria, like with the carbapenem-resistant Klebsiella or the carbapenem-resistant Enterobacteriaceae, we have to use combination therapy. It's not always that we have to use monotherapy. Monotherapy is reserved for most of the situations where we have a susceptible organism and where we have a antibiotic which achieves a good concentration in that particular site. In that situation, we can use it. But for things like multi-drug resistant TB, where we already know it is an MDR pathogen, or organisms like carbapenem-resistant Enterobacteriaceae, we will have to use combination therapy to overcome the multiple resistance mechanisms which are prevalent in our setting. So monotherapy and combination therapy have different places in different scenarios, and both of them have to be used in proper particular case-based approach is what I think.
Thank you, Dr. Vikas. There's another couple of questions here with regard to implementation of antibiotic stewardship. Could you enlighten us as to how do you engage your prescribers in continuing to do stewardship in your hospital?
So in my hospital, we have a very active antimicrobial stewardship program. In our hospital, what we do is we have a restricted antibiotic formulary. Whenever an antibiotic from that restricted formulary is used, the prescriber has to fill up a justification form for that. And that justification forms, you need to fill up the indication, the dose, and whether you have sent the cultures or not. So once they fill that up, that would be reviewed by a pharmacologist and a clinical microbiologist. And if they feel that it is appropriate, then they allow it to be continued. If they feel that the antibiotic choice for that particular indication is inappropriate, in that situation, they raise it to the clinician, which comes to me. At that point, I review the patient and all the data, the clinical condition of the patient and the microbiology data which is available with me. And based on that, if I feel that it is inappropriate, then I go along with my pharmacologist, I go and have a discussion with the prescriber, whether in this situation, this particular antibiotic is appropriate or not. So it is very important. And on most of the occasions when we have a discussion, we present the evidence to them, and we tell them that this actually is not a good choice in this particular case. In most of the situation, we are either able to bring it down to monotherapy, or either able to convince them to de-escalate to a narrower spectrum of antibiotics. So the involvement of the prescriber and a multidisciplinary team is the key component of the AMS. We need to have a discussion with the prescriber, and that is the foremost important point in antimicrobial stewardship. If we do not discuss, and I just suggest to the pharmacology team that please do not dispense, then that actually would lead to confrontation, and we may not be able to achieve our goals.
Okay, thank you, Vikas. Thank you very much. Let's go on now. So let's go on to our next case. So this is again another 45-year-old male, history of analgesic abuse for osteoarthritis, sudden abdominal pain and septic shock, diagnosed with a duodenal ulcer perforation, started on injection meropenem, gentamicin and flagyl. Systemic exam revealed a rigid abdomen. There is some mild anemia here. Blood culture doesn't show any growth. Pus culture has shown an ESBL E. coli, or extended spectrum beta-lactamase producing E. coli, which is sensitive to piperacillin tazobactam. Chest X-ray had shown an opacity in the left lower lobe. This patient undergoes surgery and then subsequently goes on to be shifted into the ICU. So my first question again is to Dr. Devishri. Dr. Devishri, in your experience, what are the common organisms in clinical practice which can produce an intra-abdominal infection here?
So the most common organisms are Enterobacteriaceae like E. coli, Klebsiella. Many times there can be Enterococcus, there can be Candida. Anaerobes also are an important component of our gut flora. So these are the common organisms that we come across.
Dr. Balaji, the next question is to you. As you know that gram-negative organisms predominate in our community for intra-abdominal infections. So what do you think are the likely resistance mechanisms that we should be aware of?
For E. coli, there is a slight difference between the resistant mechanism among the escape pathogens. So here in intra-abdominal infection, we can think of three important gram-negative organisms. The first one, the most common, or almost 60 to 70%, invariably it will be E. coli, followed by Klebsiella, then Pseudomonas aeruginosa. So these three organisms doesn't exhibit the same resistant mechanism. So it's very important to understand the background resistant mechanism profile of the country and the region. Suppose for India, E. coli, the commonest resistant mechanism, of course, ESBL are both common for E. coli and Klebsiella. The 10 type is more common for E. coli and Shiv type is more common for Klebsiella. When it comes to carbapenemase, in E. coli, 90% of the time in India, we do see New Delhi metallobeta-lactamase, and especially the variant 5. Most of the countries outside India, they do see NDM1, whereas in India, we do see NDM and NDM5 variant. So that's about the E. coli. When it comes to Klebsiella, majority of the time, it is both NDM plus OXA48. And then it's almost 60%, it will be NDM and OXA48, followed by only OXA48. Only NDM is very few numbers. So that's how the distribution is seen in India. And Pseudomonas aeruginosa, it's not the enzyme, it's mainly the efflux and the overexpression of the efflux and the deficiency of the porin channels. And this is the most common mechanism for Pseudomonas aeruginosa. Unfortunately, in Indian settings, we do see 40% of the Pseudomonas aeruginosa also express carbapenemase, mainly due to NDM and Vim. So the situation between the countries, it may vary, but in India specific, this is how we see. So it's very imperative before starting to start an appropriate antibiotic therapy. It's important to know the resistant mechanism of the organism isolated. So then you can choose the right antibiotic. So that is the profile. This is the gram-negative. When it comes to gram-positive, Staph aureus, Enterococci is the most common, followed by Staph aureus and Streptococci. And you cannot rule out Bacteroides and Clostridium. You need to take care of those two common organisms also when it is an intra-abdominal infection. So especially for gram-negatives, it's important to know the resistant mechanism will help you to choose appropriate therapy. That's all.
Thank you, Dr. Balaji. So, Dr. Divishri, the next question is to you. So, you've noticed that this patient is on multiple antibiotics. So, where do you think the stewardship opportunities here are?
So we have plenty of stewardship opportunity here. Most important is, I think this patient has achieved a good source control and he is hemodynamically stable. He is not still in septic shock. And meropenem, gentamicin and flagyl, actually it's a lot of redundant cover. Meropenem has very good anaerobic activity, so there is no need for additional metronidazole. And again, there is no need for multiple antibiotics. Like once we are giving a carbapenem, the sensitivity of gentamicin, at least in the Indian setting, is extremely low to the aminoglycosides. So monotherapy with meropenem probably could have been okay, but I feel even initiating the treatment even with the piperacillin tazobactam would have been wonderful, mainly because piperacillin tazobactam actually even covers enterococci, which is not covered by meropenem. And that would have probably been my initial choice of antibiotic actually. And once you already have a culture which is telling you that the ESBL E. coli is sensitive to piperacillin tazobactam, definitely you can de-escalate to piperacillin tazobactam. Sometimes if the patient is still in shock and all, you can probably continue the meropenem because there could be an inoculum effect and piperacillin tazobactam may not be able to tackle the situation. So if the patient is better, definitely the very good option will be to switch over to piperacillin tazobactam. And try to keep the duration of antibiotic therapy as less as possible. Maybe even 7 days with a very good source control should be appropriate.
Okay, thank you, Dr. Divishri. So absolutely right. So meropenem actually covers most gram positives, most gram negatives and anaerobes. So really you do not really need gentamicin or metronidazole on board. So definitely avoid redundant double coverage, whether it's gram negative or anaerobic. Dr. Divishri also mentioned about the inoculum effect. So this patient did have a seriously serious infection. You can see here, this is called the inoculum effect. You can the column here, you can see here, just take one enzyme here. When it's just 10 to the power of 5, the MIC is pretty low. But when it increases to 10 to the power 7, the MIC actually dramatically increases. And though this is an in vitro laboratory phenomenon, it actually correlates even clinically. There are a variety of studies which correlated clinically with regard to bacteremias and seriously ill patients. So that is definitely something to keep in mind when you're dealing with patients like this. Okay, so by a question to Dr. Vikas, I'm going to take one question here from the chat box. Can Zavicefta Aztreonam combination be given for NDMs even when Zavicefta and Aztreonam are phenotypically resistant? What about the use of Zavicefta Aztreonam for NDM E. coli? Dr. Vikas, will you be able to take this? And maybe I'll ask Dr. Balaji to quickly comment on that.
Yes, well, it's a very important question in today's scenario in the era of newer BLBI combination. So we need to understand the different resistance mechanism as Dr. Balaji was discussing earlier. And the majority of the resistance mechanism in Indian scenario in carbapenem resistant E. coli is a combination of NDM plus OXA48. So in that situation, we need to give a combination of Zavicefta and Aztreonam. Also, it's not about the genotypic mechanism. We need to make sure that we have a phenotypic synergy testing available. So based on the phenotypic synergy testing, if a combination of Zavicefta and Aztreonam, either by doing a E-test and disk diffusion or by the stacking method, by either of the method, if we are able to prove synergy of Ceftazidime avibactam plus Aztreonam for carbapenem resistant Klebsiella, then only in that situation we should be using it. We should never be using it without the complete information, and we should never be using it as an empiric therapy. The second part of the question was with regards to the NDM E. coli. See, NDM E. coli, there are multiple other mechanisms like the PVP3 insert, which actually is not taken care of by this combination. And the synergy, as per published data, is only 30-35% for combination of ceftazidime, avibactam, and aztreonam. So I would not suggest until we have complete information for synergy testing for an E. coli. However, for Klebsiella, you can consider from case to case basis, depending on the scenario. But for E. coli, I would not suggest to use it.
Thank you very much, Dr. Vikas. Let's move on to our third stewardship intervention. So this is a 44-year-old banker, comes to hospital for suture removal, operated for umbilical hernia, has a short-term Foley's catheterization while getting operated. No known comorbidities, no fever, urinary complaints. Patient was afebrile, per abdomen, no findings, system examination was normal. The patient goes on to have some tests. And these are her tests. The urine routine shows WBCs of 14 per Haifa field. The urine culture actually shows many gram-negative bacilli, many gram-positive bacilli, more than 100,000 colonies of ESBL E. coli. So the patient is started on injection meropenem IV Q8 hourly for 10 days. So, Dr. Vikas, I'm going to throw it back to you right now. What do you think? Was the treatment choice here appropriate?
So, first of all, in this situation, I would ask the clinical history whether the patient has any symptoms or not. And if the patient has no symptoms, I would not even think of sending a urine culture in first place, urine routine or a urine culture in first place itself. So if there are no symptoms, I would just label it as an asymptomatic bacteriuria, and I would not like to treat this patient. Meropenem in this situation, if the patient has no symptoms, I would not like to use it. Asymptomatic bacteria needs treatment only in few situations. One is the pregnancy, and second, when somebody is undergoing a urogenital manipulation, which involves the cutting of the genital mucosa, or earlier, according to the earlier guidelines, in the first 3 months post kidney transplant, which also now has been stopped. So I do not feel meropenem was an appropriate choice in this situation. I would go back and look at the history. If the patient has no symptoms, which I presume, because this patient has actually come for a suture removal, which looks unlikely to be the case here.
Thank you very much. Next question is Dr. Balaji. Dr. Balaji, what are the precautions that need to be taken prior to collecting a urine sample?
The most important one is the patient should not be on antibiotic. As far as possible, try to avoid giving antibiotics before collecting the urine sample. And second is midstream clean cat's urine. I think the patient needs to be educated and told very clearly how to collect the sample. So that is the second most important thing. Third, this is where a lot of people fail. The moment the urine sample, midstream clean catch urine is collected, that needs to be shifted or transported to the laboratory within 1 hour. And in the laboratory, you have to make sure that it is processed within 2 hours. Maximum between the collection and the processing should not go beyond 2 hours. Because the half-life of bacteria proliferation is 1 hour for the half an hour for the gram-negative bacteria and 1 hour for the gram-positive bacteria. So if it starts multiplying, urinary culture is a quantitative culture. It's not qualitative. Yes or no? You need to quantitate to say significant or not. For quantitation, it's very imperative, mandatory that the urine sample has to be processed at the earliest, not going beyond 2 hours. In majority of the circumstance, people are not aware and they are not paying much attention that it should be processed within 2 hours. If it is not being processed within 2 hours, it's as equivalent to not doing the urine culture, because it will give a false positive. 10 to the power of 5 or 10 to the power of 4 it will give, and unnecessarily you will be landing up with the treating unnecessarily. So misuse and overuse are very high here. So it's very important that it should be processed in time and it should be correlated with the clinical symptoms and sign. So that is more important. And if the patient is on catheter, through the port you need to collect, never from the bag. And to differentiate between the colonizer and the true pathogen, it's a quantitative. You need to look for the number. The higher the number, it's the pathogen. And you need, in case of doubt, sometimes we may have to repeat the urine culture again and then correlate. So the clinical symptom signs and the way it is processed and reported are very important.
Sure. Thank you so much, Dr. Balaji. I'm just going to take a question from the chat for Dr. Devishri. Dr. Devishri, there are many AMSP hospital activities in your hospital. What has been your experience with regard to modification of empirical therapy? And also, what do you do if the prescriber doesn't follow what you have said after the feedback that you've given?
So basically, even before you start empirical therapy, you have to look at what niche we are seeing and what is your local antibiogram. You really definitely need to look at your local antibiogram. What is the kind of patient who is presenting to you, and what is the clinical state of the patient? Is the patient doing well, relatively clinically stable, or the patient is in septic shock or MODS? So based on that, in the hospital, I think you need to draw a guideline based on your organisms and their susceptibilities. In your OPD setting, what is the antibiogram like? What is the antibiogram like in your ward? What is happening to the pathogens in the ICU? So you need to have some kind of local data before you think of empiric antibiotics. And based on that, you have to start your empiric antibiotics. Many of the times it does happen that the clinician does not listen to us in the beginning. So sometimes we do try to, if it's an OPD patient and or if the patient is relatively stable and a meropenem is started, carbapenems are actually restricted use antibiotics in our hospital. So we do try to talk to them and we try to convince them that this patient is really stable and it is less likely that this patient is also not been in healthcare contact, does not have comorbidities. So less likely that you need a carbapenem for this patient. That is what we convince. If the patient is extremely sick, we actually take time. We definitely wait for the cultures. We see what is there in the cultures. And then as per the cultures, we try to convince the clinician. Sometimes it does happen that they just don't listen to you. And it's not just one person. We try to talk to them as a team, like myself, microbiologist, clinical pharmacist, and even sometimes even if the patient is in the ICU head is also important. So it's not just one person. You need to have a good team who can try to convince them. Sometimes if that does not happen, we do get support from our hospital authorities actually. And sometimes we have tried to restrict the formulary also if the patient is really stable.
Okay, thank you very much. Let's go on to our fourth case. So definitely the message here is do not treat colonizers or contaminants. So it could have been a contaminant depending on when the urine sample reached the lab, or it could have been a colonizer, exactly like what Dr. Vikas had actually mentioned. So just to reiterate, yes, bacteriuria is not a disease and it's very, very important. It's very rarely an indication for antibiotics, and Dr. Vikas had very nicely alluded to what exactly were the indications in case of an asymptomatic bacteriuria for treatment. Okay, so this is the fourth case, a lady who has a subcutaneous panniculitis T-cell lymphoma, given the first cycle of chemotherapy on 3rd of September in 2016. She is given CHOP-E, which is cyclophosphamide, adriamycin, vincristine, etoposide, and prednisolone. She presents with fever, cough, and expectoration with loose stools for 2 days, some odynophagia, and then ENT rules out a peritonsillar abscess. She has no breathlessness, or oliguria, or hematuria. These are her vitals. You can see here she's hypotensive. She's tachycardic, she's febrile, she's pale, seems like she's jaundiced. She's also got some erythema and swelling on the medial aspect of the right thigh. It's not clear what it is. She has a mild hepatosplenomegaly and she has some conducted sounds. She's in ICU for observation, requires a small dose of inotropes and oxygen by mask. She's neutropenic. She's actually pancytopenic. Her hemoglobin is low. Her total counts is low. Her platelets are also low. So she was started on meropenem initially and then escalated to colistin within 5 hours. And qualitative PCR for influenza comes back as positive. And this is her chest X-ray. So my question here to the panel, we've obtained the blood culture. The blood culture shows a very nice E. coli. So my question here, first question is to Dr. Vikas. What are the common causes of bacteremia in a sick patient in hematology department either post-chemotherapy or post-transplant? What are the usual organisms that you would see in a bacteremia?
So the common organisms post-chemotherapy or post-transplant are predominantly the pathogens which are transmitted from the gut because of the mucositis, which has been severe mucositis, or the top layer of the mucosa which has been denuded because of the cytotoxic effect of the chemotherapy. These are mainly Enterobacteriaceae, E. coli, Klebsiella. Along with that, in the neutropenic patient and the transplant patient, Pseudomonas is a very important pathogen which we always need to keep in mind. And most of the guidelines actually for febrile neutropenia are based on the fact that they always want to cover Pseudomonas in their pathogen list whenever they are selecting a prophylactic regime for antibiotics or an empirical regime for the antibiotics. The gram-positives are also an important pathogen, but majority of the studies have actually shown that if you use an empirical gram-positive coverage, there's not much benefit in terms of mortality benefit when you are using it empirically. So Enterobacteriaceae plus Pseudomonas are the two, along with Pseudomonas, I would feel is the most important pathogens which we need to keep in mind when we are dealing with post-transplant and neutropenic patients.
Thank you, Dr. Vikas. My next question is going to be addressed to Dr. Balaji. Dr. Balaji, you've seen here that this patient has an E. coli which is pan-susceptible. And you can see here the blood culture and susceptibility is given by Vitek 2 here. May I ask your opinion on automated blood culture systems? When are the situations when we should not depend on them, and when are the situations when we can trust the results? Dr. Balaji.
Yeah, usually all the automated systems that are available for the use are FDA approved. So we can use it, but there is a catch. FDA approval is not as a blanket approval for all the drug-bug combination. So there are certain drug and bug which has not been FDA approved. So those kind of information will be available in the manual which accompanied with the platforms, Phoenix, BD Phoenix or Vitek 2. So it's the important knowledge the microbiologist should know whether this has been approved or reliable for this bug-drug combination with this platform. So wherever it's not reliable, it's better they should depend on manual, either DD or MIC, not by the platform, by that particular platform, because all the three systems may not be available with every clinical laboratory. Only certain systems, either bioMérieux or BD platforms only will be available. So they should be knowledgeable about that platform's weakness and strength. And accordingly, they should interpret where it's reliable, not reliable. And if it is not reliable, they should set up manual testing and give the report. One simple example I can give is, Vitek 2 doesn't have an meropenem approval for Acinetobacter baumannii. It may not be correct. So like that, what we do is we conduct external quality assessment program. In that, we will give this kind of challenge organisms for different platforms and we educate them. So it's important for the microbiologist to understand and appropriately advise the clinician. Thank you. It's a very important question which you asked me.
Okay, thank you, Dr. Balaji. My next question is to Dr. Divyashree. Dr. Divyashree, you noticed that this patient was on meropenem and colistin. And now, based on this blood culture report, what is your stewardship opportunity here? And I think there are some questions in the chat about how you would actually de-escalate antibiotics in this very sick patient.
So once you have a culture, it's very good that we have a culture which is telling that there's a susceptible organism. Actually, you can definitely de-escalate this patient to cefoperazone sulbactam. The other option will be, because she's sick, I think again the other inoculum effects and other things come. So as per the Merino trial, you can, I think colistin can be stopped and the patient can be kept on meropenem. And she also is having some kind of, she's again positive for Staph aureus also in her blood. So you need to start her on appropriate treatment for the Staph aureus. Here, starting her on cotrimoxazole, I would be a little hesitant because she's already having so much of cytopenia. So I would like to, I'm not very sure whether this is a MRSA or MSSA. If it is MSSA, your meropenem will take care of the MSSA as well. If it is MRSA, then again you have to start her on probably teicoplanin or vancomycin.
So Dr. Devashri, do you think, sorry, go ahead.
So once you have a culture, your job is very easy. De-escalation is extremely easy. But if you did not have your cultures, then I would be very skeptical in, de-escalating any patient, especially because she's in shock and she's pancytopenic.
So do you think it is safe to de-escalate in this patient who is hypotensive and neutropenic?
I mean, you have a culture, and you also need to see if there is any other source that she's having. Like suppose she is having a chemo port from where the Staph aureus has grown, then you need to have a source control also. So in case there's a central line and it was probably a CRBSI also, you need to try and have a good source control.
Thank you so much. Okay, so I think that's excellent. So de-escalation of empirical therapies are very common questions from the ICU physicians because they're very, very hesitant to actually de-escalate, especially when the patient is in severe sepsis and shock. So there is evidence definitely, but even with patients with severe sepsis and septic shock, de-escalation turns out to be protective. So it is very, very important to keep that in mind. Let's go on to our last case, and then we'll take all the questions from the chat. This is a 57-year-old man with fever and dry cough for 3 days. He's diabetic, hypertensive, hypothyroid with chronic kidney disease, which is stage 5. He requires hemodialysis. You can see here he's mildly hypertensive. His saturation is all right on room air, not the best, but it's still okay. He's anemic and he is in renal failure. You can see your creatinine is quite high. Microbiology wise, really nothing significant so far. He's rapidly worsened and he's on a ventilator. So he started on meropenem 500 milligrams Q12 hourly, correcting for his creatinine. So this is his chest x-ray here. And you can see here there are infiltrates bilaterally. So my first question will be to Dr. Vikas. Dr. Vikas, what do you think are the diagnostic possibilities here for this particular patient?
Well, this is a patient who is a known case of diabetes, hypothyroid, and chronic kidney disease on dialysis, has presented with a syndrome of bilateral interstitial pneumonia. In this situation, looking at her presentation of fever, cough, and a respiratory distress, I would think, and looking at the chest X-ray of bilateral interstitial infiltrates, I would look at the differentials like community-acquired respiratory viruses like H. influenzae or COVID in the current era. Also, if it would have been a unilateral or a lobar kind of consolidation, then in that situation, I would have also thought of strep pneumo because she is a high-risk candidate to get strep pneumo lobar pneumonia also. I would also look at some of the non-infectious etiologies because she is a patient who has a CKD. I don't know when was the last time she had a dialysis. So I would also look at things like fluid overload or congestive cardiac failure because of the chronic kidney disease. So those would be my thought process.
Thank you. So Dr. Vikas, in your opinion, what are the lab tests you will send at this point in time to confirm your diagnosis?
So I would quickly send since she is intubated, we can do a bronchoalveolar lavage, or we can even send an ET aspirate, but bronchoalveolar lavage would be a better sample. We can do a respiratory PCR on that to look for both H1N1 RT-PCR and a COVID RT-PCR on that. So that would be my first thing. Along with that, I would send a gram stain and an aerobic ET and BL for aerobic culture also.
Okay. Okay, so the test here comes back as influenza positive here. Dr. Devashri, what would you think would be the stewardship opportunities here in this particular patient? Let me go back to the case.
So basically, this is a patient with a lot of comorbidities, and although he is having influenza, they also have a very high risk of having coexisting bacterial infections. Some of the most common infections are like strep pneumo, H. influenzae, and sometimes even Staph aureus is common in these patients. So I feel if the patient is otherwise, not requiring too much of oxygen, not on inotropes, I think meropenem is a little too much of an overkill. Probably something like a ceftriaxone, and send the urine, antigen test for strep pneumonia, and even Legionella and see what comes. I think that this patient also has a component of failure which is happening here, like, his hemoglobin is 7.6. So correct the anemia, try to stabilize him, see how he does. Meropenem, I still feel is too much of an overkill. Start him with ceftriaxone, send all the relevant cultures, see what is there in the gram stain, and then take it forward is what I think.
So, in your opinion, Dr. Devishri, if you do a procalcitonin here or a respiratory viral sample, would it help?
I mean, already respiratory viral sample is already telling you influenza, so you have to take care of the influenza, and you also have to, procalcitonin will definitely help you in de-escalating. It's a good agent for de-escalating. And of course, we have to see the patient's clinical condition also. How are the respiratory parameters improving, and is he going into something like a septic shock or something is what we'll have to look into it. Every time an antibiotic is prescribed, we have to keep on thinking like whether, he needs escalation or can be de-escalated. And if we have sent relevant cultures and we have some help from the cultures, it's going to be really good.
So absolutely. So rapid diagnostic point of care tests can reduce antibiotic use. You can see here when you have access to respiratory viral panels, it can actually definitely reduce your antibiotic use in most cases. And then also biomarkers like procalcitonin and rapid diagnostic tests can reduce initiation, duration, and total exposure of antibiotics. My question to Dr. Balaji is here would be, Dr. Balaji, there are a variety of tools that we can employ for diagnostic stewardship, procalcitonin and rapid diagnostic tests. What are the things in bacteriology that will help us rapidly to be able to initiate the most appropriate antibiotics?
See, a big question is if the laboratory can afford to have the latest technology platforms like MALDI-TOF that will expedite the identification of the pathogen within 6 hours or even less than 6 hours. So that is most important. Now, accelerator, Pheno accelerator is another platform which is available in the America and Europe, but it's yet to come to Asia. So that kind of platforms, if it comes to the middle income countries, definitely we can improve our antimicrobial stewardship, means diagnostic stewardship, much better. And the second one is making even these two biomarker, procalcitonin and rapid diagnostic tests in most of the hospitals, availability and the infrastructure capacity building, if it's provided, even large, to great extent, it will reduce the misuse and overuse of antibiotics. So in the corporate hospitals, big platforms, availability of the newer generation platforms, and the existing one, bringing in the biomarker and the rapid diagnostic test availabilities are important.
Thank you very much, Dr. Balaji. So just to kind of recap, antibiotics are not harmless. They can predispose to Clostridium difficile colitis and candidemia. They wipe out the good bacteria in the gut, and they leave the multi-resistant bacteria to proliferate. This goes on to being passed around in the hospital and in the community. And these resistant genes can be passed on to other bacteria in the hospital, making other infections difficult to treat as well. And of course, the costs remarkably go up. So I'm going to summarize before we start taking the questions in the chat here. So what are the do's and don'ts of antibiotic prescribing? Do make a clinical diagnosis, do send appropriate lab tests to confirm the diagnosis, do look at local susceptibility patterns and the PK/PD of the antibiotic that's prescribed. Do de-escalate, discontinue or modify it once you have a culture test available. The only situation where you may need to urgently treat would be necrotizing fasciitis, bacterial meningitis, community-acquired pneumonias, ventilator-associated pneumonias, and febrile neutropenias. Avoid antibiotics, so don't give antibiotics for just a fever. Always make a diagnosis so you can come back and revise your diagnosis and make sure that your antibiotic is definitely needed. Don't treat any colonizer or contaminant. Don't give antibiotics for duration longer than necessary. Don't give antibiotics without checking if it will work at the site of infection. And we have many examples with regard to that, whether it's daptomycin in lung or echinocandins in urine. And don't assume that if the person has not responded to the antibiotic, that immediately it is a drug resistance. It can be some other reason, that is maybe the drug is not being absorbed, or maybe it's being washed out, or maybe the person's GFR is very high. So always look at low-hanging fruit. That's my favorite clip art. Look for low-hanging fruit, which you can implement in your setting, whichever setting it is, whether it's primary care, secondary care, or tertiary care with regard to antibiotic prescribing. So I think that was my last slide. Please look at the WHO stewardship programs, which this is a very nice practical toolkit which can allow you to implement the program in your particular setting. I'm just going to go quickly to the chat here to answer some of the remaining questions in the last 20 minutes or so that we have. I'll see what the questions are, which I did not actually take up. Okay. So a patient arrives at a hospital with some infectious problem. Now, should the clinician choose to go for a lab test of some resistance or sensitivity, or opt for any access group of antimicrobial alongside the diagnostic testing? This is especially important in the case of OPD patients, pediatric patients, as well as for serious infection presentation. So patient comes in, should you choose a lab test or should you go for an access group antibiotic? I will address the question to Dr. Vikas.
So basically, the most important thing whenever we are prescribing antibiotics is to make a diagnosis, first a clinical diagnosis, and then by sending appropriate samples, be in the form of blood tests or cultures or from the local site cultures, to try and establish a diagnosis. There's a very popular saying in ID, don't cover, just discover. So we always like to make diagnosis, and it is very important to have a clinical diagnosis, and based on that clinical diagnosis, we send out lab tests to try and establish that working diagnosis. And based on the most likely diagnosis and the most likely pathogen at that site, we select antibiotics to target that pathogen. Once we start off with empirical antibiotics in that situation, and once we have the lab reports confirming our diagnosis, if we are able to de-escalate to a narrower spectrum, or if we are able to switch to an oral drug, provided the patient has improved clinically, then in that situation we should try and do, because both of them are very proven, very good antimicrobial stewardship practices. So first and foremost is our clinical judgment at the bedside, be it in OPD or in the IPDs. Then try and making a diagnosis, sending out appropriate samples, and try and select an antibiotic which achieves a good concentration at that site, targeting that particular pathogen. And then once we have the reports back, then and if there is a clinical improvement, then readjusting our antibiotic therapy based on that. So that is usually my approach whenever I'm dealing with a patient, be it in OPD or in an IPD setting.
Okay, so another comment in the chat is, most of the hospitals or tertiary care setting, the sample taking is main theme. Do we have to evaluate methods and train the staff to take the swab or the sample? I think with COVID, swab taking is not difficult. I think most people in the primary care, secondary care, and in the tertiary care have been trained with regard to taking swabs. So I think Vikas's point was well made, that you have to make a diagnosis first. So whatever the patient presents, make a diagnosis. Maybe the person just has a runny nose and a fever. You don't really need samples to be taken at the first shot. You will evaluate, make a diagnosis. And we already mentioned throughout the presentation here that if the person has a viral illness, there is no point even starting antibiotics. You will send the patient, call them back, and ask them to report if there are more serious presentations. So my next question is to Dr. Devishri. So surgical, we usually give prophylaxis for most surgeries. And this is widely practiced in tertiary care settings. How does this contribute towards antimicrobial resistance?
So yeah, surgical prophylaxis, I mean, basically what we are trying to cover here is basically the skin, organisms which are there, which may eventually go and initiate a pathogenic process in an appropriate host. So the whole concept of surgical prophylaxis is to give a very short interval where it achieves a very good concentration, and it is present for a very short duration where it does not promote resistance also in the person. So it's basically a single shot of the antibiotic. Most commonly what we use is a second generation cephalosporin, which adequately covers the skin pathogens. So resistance actually can happen if we actually try to give the antibiotic for a longer duration, or suppose we are trying to extend the spectrum of the antibiotic that we are giving. Generally, as I said, the second generation cephalosporin is quite enough. A lot of people try to, give BL, BLI, or sometimes they try to give vancomycin, even if the MRSA incidence is not very high. So we have to cut down on this, and we also have to, involve the whole team. You have to have a good team, good rapport with the OT people, with your surgeons, with the anesthetists. Try to have a good, antibiotic prophylactic program also. This also comes under the purview of antimicrobial stewardship. So that's why you have to choose the drug optimally.
Okay, thank you, Dr. Divyashree. My next question is going to be to Dr. Balaji. Dr. Balaji, there is a question in the chat about using two agents from the same class, for example, cephalosporins, monobactams, carbapenems, and penicillins. In your opinion, what is your opinion with regard, when do we consider two antibiotics being given together as synergistic versus additive versus antagonistic? How do you actually assess that?
Actually, between the same class, it's all beta-lactams. I don't think that combining the beta-lactams will add value. So far, I don't see anywhere such recommendation exists. Only for KPC infection, double carbapenemase was tried. Other than for KPC, nowhere else double carbapenem or double cephalosporin, penicillin cephalosporin were recommended. So especially for double beta-lactam, in certain situations, yes, especially for Staph aureus and the Enterococcus, where it binds to two different targets, PB2 or PB3. One beta-lactam will target PB2, another beta-lactam will target PB3. In those situations, yes, very recent recommendations are there, especially for Enterococci. Earlier, they were recommending aminoglycoside and beta-lactam. Now it's double beta-lactam. Similarly for Staph aureus, double beta-lactam. So these are all the places where strongly double beta-lactam therapies have been recommended. Very recently, they have seen RCT proven evidence to use that one.
Okay, thank you, Dr. Balaji. Thank you for telling us specific situations where you would even consider double beta-lactam. So yes, there has been in vitro evidence with regard to using two beta-lactams, especially when there is resistance, so especially methicillin-resistant Staph aureus. My next question is to Dr. Vikas here. Dr. Vikas, in febrile neutropenia, when cultures are negative, how long do we wait before escalating antibiotics? Do we combine antibiotics, or do we stop the existing one and escalate? How do we actually go about managing a patient?
Febrile neutropenia is a very tricky situation. First of all, whenever we have a patient of febrile neutropenia, we should try and look for three things. One is the first one is the whether it is a high risk or a low risk neutropenia. That we can do easily by calculating that MASCC score or a CISNE score. The low risk neutropenias are not the ones which will pose great difficulty, and they should recover with very few interventions. However, the high risk neutropenias, that is those who have prolonged and profound neutropenias, are very, very sick, and these are the hosts whose immune responses have been blunted for a very, very long time. So in those patients who are high risk neutropenia, in that situation, if the fever is persisting and we have not been able to make a clinical or a microbiological diagnosis, then in that situation, provided the patient continues to be hemodynamically stable, there is no hemodynamic worsening, I would continue with my initial antibiotic of choice. And if the duration of neutropenia has actually gone beyond 7 days, then in that situation, and if there is a prolonged and profound neutropenia, prolonged and profound, I mean neutrophil less than 100 and the duration has lasted more than 7 days. So in that situation, I would even use the biomarker-based therapy. I would do a serum galactomannan and beta-D-glucan to look for yeast infections or the mold infections, which are very common in that subset of patients. But I would not just go on empirically adding one antibiotic on top of other if the patient is hemodynamically stable. And also there is a very good evidence which is now available in terms of Cochrane systematic review, which provided information about the use of empirical gram-positive coverage or adding gram-positive coverage for febrile neutropenia patients. That Cochrane systematic review showed that there is no benefit in terms of mortality if we use empirical gram-positive coverage in a febrile neutropenia patient. So febrile neutropenia, you need to look at a lot of factors. If the patient continues to remain febrile and neutropenic, and he's hemodynamically stable, I would not suggest adding another antibiotic in terms of or a gram-positive coverage or adding another antibiotic to cover for an MDR pathogen. If the situation changes, if the patient is rapidly worsening, if there is a hemodynamic worsening, then I would reassess my situation, try and make a diagnosis again, send fresh cultures, do biomarkers for infections like beta-D-glucan and galactomannan in that situation, and then tailor my therapy according to that situation. And also at this point, the role of local antibiogram comes in. You need to know the local antibiogram in your hospital, especially in the febrile neutropenia or the hematology setting. That also would help you in selecting your antimicrobial in that situation.
Thank you very much, Dr. Vikas. Dr. Balaji, the next question is for you. Whitetech-2 is not approved for which of the organisms? You're muted.
Whitetech-2 is not in a microbroth dilution, unlike a Phoenix PD and other platforms. So you may find it a little mismatching with quite other platforms. So the most important one is imipenem meropenem for Acinetobacter baumannii. There are quite a few mismatches happens. Offhand, I don't remember. There is a long list is there, but significant list is there.
Okay. Next question is to Dr. Divyashree. Dr. Divyashree, when would you actually advise source control when you have a central line associated bloodstream infection in a febrile neutropenic patient? So it's not easy to put in another line. So what are the specific situations where you would take the line out when you're unable to, in a febrile neutropenic patient, when you have a bloodstream infection?
So, I mean, source control is the most important aspect, especially when you're having a febrile neutropenia patient. And you should be really sure that the chemo port is the actual source of infection. Sometimes it may just be like the blood culture from the peripheral line as well as central line is growing the same organism. It may not necessarily be the central line, I mean, which could be the source. So in a hemodynamically unstable patient, and if you're, it's a proven, the time to differential positivity is positive, then in those situations, you will have to remove the chemo port. And again, in these patients, it's very difficult to obtain a new line because of, pancytopenia. The platelets will be very low, and again, they'll be coagulopathic. So it's actually a difficult situation to manage actually.
Okay, thank you. Dr. Divyashree, would you also like to kind of give your opinion on the combination of amoxicillin and cloxacillin? As you know, Ampiclox was available a while ago. What is your opinion on that?
I mean, I don't find it a rational combination because probably the spectrum is going to be, cloxacillin is almost the same and amoxicillin may not add anything great to that. So if you want to increase the spectrum, probably making it a amoxiclav will be a better option where you get a more broader coverage, like with anaerobes and a lot more extended coverage. Cloxacillin does not make any, I don't find it a rational combination.
So thank you very much. So actually, this has been banned according to the government now, and there is a list of banned drug combinations which are available on that particular website. So on the DCGI website. So this would not be considered very useful. Now, Dr. Balaji, question for you. In a rural setup, it's very difficult often to send cultures. and they're usually quite unaffordable, and they are exorbitantly priced because most often they have to send it to the local laboratories. So what can we do to improve this particular situations? Are you aware of any particular steps taken by the local and national governments?
So it's very unfortunate. At least if they have a local profile, sample profile in the primary healthcare center or in a district level, usually we don't need to worry much about the antimicrobial resistance at that level. Primary healthcare settings and the secondary healthcare settings. Even now, they can manage easily without carbapenems. Only post-surgical inpatients, the problem comes, and especially tertiary care and in the urban areas, I do see a lot of problems. Generally, we don't see much of a problem in the primary and secondary care. If at all, if there is a surveillance and a cumulative antibiogram and antibiotic policy, I think that should suffice. I don't think that you need to subject every other patient for a culture in those areas.
Thank you, Dr. Balaji.
Indian settings I'm talking about, because it's very difficult to bring in a microbiological culture system in those setup, primary and secondary healthcare settings.
Sure, thank you so much. So actually, if I may add on, we had helped institute antimicrobial stewardship in 4 secondary care hospitals, and I was actually just correcting the manuscript before this webinar, and it's thankfully very gratifying to note that the prevalence of multi-drug resistant organisms is actually pretty low in that setting, and we need to keep it that way. So it's very, very important to educate the secondary care and the primary care doctors as to what to do in a situation, and when exactly would you think in terms of instituting antibiotics. So I totally agree with Dr. Balaji. The resistance at the moment is pretty low in these settings. And of course, if they come in and you send cultures, you find resistance, it may be better to actually refer them to a tertiary care setting where they have access to advanced culture techniques. Dr. Vikas, what is your opinion on procalcitonin, apart from its use as an agent which can help with antimicrobial stewardship? For diagnosis of infections, what is your opinion?
Procalcitonin does not add much value in terms when you are using it for a diagnosis. I mainly use it for de-escalation strategies, and that too there is only evidence only in terms of respiratory infection, pneumonias. The most of the evidence for de-escalation also while using a procalcitonin guided therapy is in the pneumonias. So whenever you see an 80% decline in procalcitonin, it means that the patient is improving and you can actually safely de-escalate the antibiotics whenever you are dealing with the pneumonia, be it community-acquired pneumonia or a hospital-acquired pneumonia. However, in terms of diagnostic, it actually does not help much. The only situation where I feel I can use it in my clinical practices in when somebody has come with a interstitial pneumonia and there is a concern about whether it is a viral or a bacterial pneumonia. In that situation, if the procalcitonin is negative, I am more intent towards thinking it in terms of viral pneumonias. So in that situation, I use it. Other than that, there are many situations which people don't know in which it is actually falsely elevated. So it is actually falsely elevated in CKD, burns, trauma patients, acute MI, somebody undergoing a dialysis, somebody on immunoglobulin therapy, and many other situations. So many times when clinicians use it without the complete information, they actually feel that the procalcitonin is very elevated. It is around 70, 80, or 200s. So it gives you a false sense that this could be a bacterial infection. And this actually leads to an unnecessary use of antibiotics. And also other problem with procalcitonin is that it does not tell you the site of infection. It does not tell you the nature of the infection, and it does not tell you what bacteria is actually causing the infection. So to me, procalcitonin has a very limited value in clinical practice. Only one value, which is in de-escalation in the respiratory infections, and second in deciphering in interstitial pneumonia between a bacterial and a viral pneumonia.
Okay, I think we're almost time. My last question is, what is the... Do we still practice extended infusion for carbapenems? And is this a common practice in wards or ICU, Dr. Divyashree?
Yeah, I think it's very important to optimize the pharmacokinetics and pharmacodynamics of any antibiotic. It's not just for resistant bacteria. Even if you want to prevent resistance in any bacterial infection, to prevent upcoming resistance, it's better that you try to give antibiotics, especially meropenem or even cephalosporins as extended infusion, especially the penicillin group of antibiotics as extended infusion. And we practice that actually in the ICUs and in the wards. I think we need to ask Balaji sir also about his opinion on this.
Sorry,
Okay, that's okay, Balaji. I think we're almost time. So, Terence, we're at 1:59. Would you want us to wrap up? Terence or Eugene? I'm not able to hear them. Terence, is it okay for, it's 1:59 p.m. Is it okay for us to take the rest of the questions, or what would you advise?
Yes, we can begin to wrap up. Maybe we can just add 2 or 3 minutes just to finalize everything.
Sure. So I think a quick question is with regard to treatment of asymptomatic bacteriuria. I think we did have a discussion during the presentation as well. So yes, we would try not to treat, we would not treat asymptomatic bacteriuria, and it's unlikely that you will get rid of it. In situations where you have to have a urological procedure, where you have to catheterize the urethra, you can use fosfomycin 1 dose before you actually perform a urological procedure. And I think one question was, does minocycline have a role in bloodstream infections? I think I'll ask Dr. Divyashree, have you used minocycline for a bloodstream infection?
Yeah, we have used minocycline for bloodstream infections in situations like, sometimes Stenotrophomonas, atypical bacteria, especially Elizabeth Kinga, Meningoseptica, few atypical bacteria, especially in patients who have been in the hospital for a prolonged time, who have had exposure to the commonly used antibiotics. In these patients, you get a lot of these kind of bugs. In these patients, minocycline is actually a very wonderful drug. It's a very wonderful drug, and it's very precious in these situations.
Okay, so thank you very much. For Acinetobacter. She mentioned that, I think.
Yeah, but Acinetobacter, I mean, yeah, I thought that was more like a pneumonia. So.
Sure. All right. Okay. So I think we are almost at the end. We are at 2:01. I'd like to thank the panelists for their wonderful interaction and the participants. I will hand over now to Terence and Eugene to take over from us.
Hello, can you hear me now?
Yes, we can.
Okay, thank you. So I hope there is no echo from our side. All right, thank you very much, Dr. Priscilla, for the excellent presentation and taking us through the principles of antimicrobial stewardship. It really was an excellent, very informative and interactive session, and we really want to appreciate you and all the panelists for taking us through antimicrobial stewardship. Just to also thank all the participants for joining us today for webinar. We really appreciate your presence, and please continue to follow us on our antimicrobial stewardship web page, and all this presentation will be posted in the web page. And just to inform you that our next webinar will be on the 15th of June. We will hold this webinar also in collaboration with CMC Valo. It will be on antimicrobial stewardship in COVID-19. So at this point in time, I would like to thank everyone, and please feel free to reach out to us for any questions, any comments. We'll be willing to respond. And if you have any specific support that you may require, maybe at health facility level or at national level, please feel free to reach out to WHO. You can reach out to us directly, or you can contact our respective country offices. So at this point in time, I would like to thank you. Goodbye, everyone, and have a great day. And please stay safe and stay healthy. Bye for now.
Bye, everyone.
Bye, everyone.
Bye.
Have a good day.